Hey guys, it's Dr. May. Thanks for joining me for this part 3 of my 3-part series on psychogenic non-epileptic seizures. This one is mostly focused on treatment strategies and also a little conceptualization of the disorder as well. So compared to the first two parts, it's a little more psychological. So I particularly am interested in this one, and I hope you'll benefit and enjoy it as well. So here we go. So treatment strategies for PNES. On my first two videos, I covered the first 4 points on this agenda here, and today I'm going to cover the last 3. So we're going to go over different treatment modalities that should be involved when you're getting treatment, psychological treatment strategies in particular, because I'm a psychologist, and also some likely treatment outcomes based on the research. So here we go. Just a quick review, although I did go over this in the first 2 videos. So what is PNES, or psychogenic non-epileptic seizures? So they're a type of functional neurological disorder. So that means that there's sensory motor symptoms that are not created by physical causes. It's created more by a psychological cause, or there's no clear physical cause for it. They're paroxysmal, which means they come on suddenly or involuntarily. So the seizure-like activity just kind of comes about out of the blue. They're time limited, although they can last quite a while depending on the episode. There's alterations in behavior, motor, and sensory symptoms. And they could occur with or without alterations in consciousness. So you might be aware during the seizure, or you may not be aware or have some partial awareness. And they could look like or mimic epileptic seizures, but they don't have the abnormal EEG changes that you would expect to see. But they still could be, very challenging to cope with and need certainly treatment. Okay, so treatment is very important to make it a team effort so that you have different key professionals involved communicating together and working together on the same goals. So instead of being bounced from one treatment provider to another and nobody's truly giving you the right advice or the right treatment, it's important to have people who know what they're doing and who also communicate. So really important. So assembling the proper treatment team is an important part of the treatment effort and can make a big difference in the successfulness of the treatment. So first, important to have a neurologist or an epileptologist on board. So even if you got the video EEG and you were diagnosed with PNES rather than epilepsy, it's still important to have a neurologist or epileptologist involved in your treatment. They shouldn't just dismiss you and send you only to psychology or psychiatry. So a lot of times you might have other conditions related to the seizures that tend to be co-occurring with it that they could still address, such as headaches, or you might even have PNES plus regular epilepsy, which is in a small percentage of cases, but still could happen. They might want to work with you to determine how and when to taper off of anti-epileptic drugs if you don't have epilepsy. And if you have a lot of the PNES symptoms and you end up being brought to the ER by people, even if it shouldn't have been happening and they shouldn't have brought you to the ER, but if you are brought to the ER, there's still a point person that the ER doctor could communicate with to know how best to treat you. Because sometimes ER docs may not know much about PNES and they might give you treatments that you don't need, such as drugs or even intubation. So it's important to have a doctor who knows your condition, who's on your side, that could communicate with the ER just in case someone brings you there. Okay, so next, a lot of times, for most cases, there's underlying psychiatric or psychological problems fueling the PNES. So it's important to have a psychiatrist on board to medicate any underlying psychiatric disorders that might be contributing to the PNES symptoms. So if you see a psychiatrist, he might even say, you should stay on your anti-epileptic drugs because there's mood stabilizing properties to them, and that's still helpful for you. Or maybe he would medicate underlying anxiety or depression, for example. So good to have a psychiatrist involved and communicating, again, with a neurologist or epileptologist. And finally, a psychologist or a social worker or some kind of a therapist that is open to learning about their condition or knows already how to treat PNES, which is probably a little bit more rare, but is also willing to work with you and communicate with your neurologist and your psychiatrist. So they could address the underlying psychological conditions such as anxiety, depression, PTSD, trauma that could be fueling your PNES episodes. And I'm going to go into that kind of treatment more later in the video. Okay, but again, communication is really important. Okay, so next, so let's focus on the medication aspect a little bit more. So if you have PNES and you don't have epilepsy, it's important to come off anti-epileptic drugs. So if you were previously medicated for epilepsy and then they realize you don't have epilepsy, you shouldn't be taking medication that you don't need. So it could also be that maybe in the past you truly did have epilepsy, but then the epilepsy subsided and now you develop PNES. So if that's the case, that's also something you can work with your neurologist and your psychiatrist. But again, if you happen to have an underlying mood condition and they feel that the anti-seizure medication can help with that, that's something that could be discussed as well. But I can't tell you as an outside person, if that's the case, you would really have to just work with your own doctors on that. Okay, so psychological treatment modalities. Okay, so there's actually some research that shows that there's certain modalities that can be effective, at least for some people. So CBT, cognitive behavior therapy, and there's even this thing called neurobehavior therapy, or CBT informed psychotherapy. That's a CBT IP. There's a special program they developed specifically for people with PNES, like a manualized treatment that's about 15 weeks long, that addresses some of the common underlying factors that could fuel your PNES. And that's something that you could find a therapist who already knows how to do that, or you could ask your current therapist if they're willing to buy the book that teaches them how to do that, and it shouldn't be too hard to learn. You could also buy a book to work with it on your own, or just have a therapist who's willing to kind of work with you on whatever the underlying issues are. Next, mindfulness-based therapies. So having some kind of open awareness of your symptoms with kind of directing kindness and compassion toward them and not judging them and not overreacting to them could be helpful, and creating a different response rather than getting overly excited and building yourself up into a seizure. So that's some of the things that the mindfulness-based therapies would work on, and we'll discuss that a little bit more later as well. Psychodynamic and interpersonal therapy. So these therapies kind of dig a little bit deeper into some of your underlying issues and interpersonal stuff, and it deals with the here and now connection with your therapist and what goes on in the relationship, and could help you generalize some of those relationship issues and patterns to other people in your life and work through things in the therapy with your therapist. Prolonged exposure for comorbid PNES and PTSD. So they're currently doing research on that. So Lorna Myers, who's big into PNES psychological treatment, is involved in a study on this. And I recently attended an online conference, and she shared that they're doing research on this. And so far, it looks pretty promising. So if your underlying issue is PTSD and that's fueling your PNES, if you treat the PTSD with prolonged exposure, which is a kind of a popular treatment for that, then your PNES episodes might also begin to resolve. So that's promising and good to know. But interestingly, she said that they're comparing it to psychoeducation. So just kind of like learning about the disorder and your symptoms and stuff like that. And it's almost just as effective, believe it or not. So just getting psychoeducation is just about as effective as getting prolonged exposure, at least at this point in the study. They're still going to do longer term follow-up and get more data on that, but that's what they said is currently the case. Also family therapy, because if there's family dynamics that are creating stress in you, then that could be addressed in therapy. And if the family starts to get along and work a little better together and be a little more healthy in their interactions, that might put the stress level down and also bring your seizure frequency down. So getting the family involved in certain cases could be a helpful modality, a helpful choice. Other modalities that have been used, but maybe not researched, at least I haven't found it. DBT, which is my specialty, ACT, which is acceptance and commitment therapy, kind of has some mindfulness components, some acceptance, some values work, some thought diffusion, like not taking your thoughts too seriously, disconnecting from them a little bit. Different trauma therapies. So if your underlying issue, again, is PTSD or some kind of related complex trauma, working with that through any of the standard trauma therapies can be helpful. Hypnosis has even been used. I'm not trained in hypnosis, but people who are could probably do some good work with that. Motivational interviewing, so it's kind of like getting you focused on what your goals are and what you really want to work toward in the future and how you want to focus your energy and bringing your behavior in line with all those things. So it kind of gets you more motivated to, let's say, work on the things you need to do to manage your seizures, because that could be hard work. And also, there's PNES support groups, and some people find that comforting just to see other people going through the same thing and share stories and share helpful tips together. And there's also online forums for that and blogs and Facebook groups and so forth. So those are some of the key modalities. Again, so psychoeducation was actually seen to be a pretty effective treatment. And also when someone's first diagnosed, it's important that the doctor provide adequate psychoeducation just so you understand your condition better. And there was even a study I saw where even just being given a good pamphlet about PNES was helpful for people. And there's also some really good resources online. So if you're just looking into it yourself, in addition to some YouTube videos, such as the ones I'm trying to provide for you, there's a couple of websites. Non-epilepticseizures.com, which is Lorna Meyer's website, has a lot of good stuff for just lay people, for people going through this, for family members and people who know people with PNES, plus some research articles and stuff as well. And also, there's a lot of free research articles online. So if you're more of a professional looking into this, just type in some keywords and, PDFs of journal articles come up all over the place for free. That's where I found a lot of my information, by the way. Also, non-epilepticattacks.info/index.html. That's the one from the UK, because they call it non-epileptic attack disorder, NEAD. So they have a website that also has some really good information at that website. So if you want to do some psychoed, it's free and easy. You could check out those two things first. You could Google some of the key people that are involved in PNES, who I listed down there. So Kurt LaFrance, Lorna Myers, Gaston Baslett, and Marcus Ruber are some good people in the field. There's a couple of Facebook groups I found. Psychological Non-Epileptic Seizures is one. And there's one just called PNES, and some people write in and share their experiences and offer support to each other and resources and so forth. A couple of books that I found that I read that are good for just everyday people and might be comforting as a person going through PNES to read it, and also as somebody who knows somebody or a professional even. So one is called Psychogenic Non-Epileptic Seizures, a Guide. So that's by Lorna Myers, the one who I was mentioning does a lot with treatment of PNES in like a more of a therapy, psychology kind of a way. And interestingly, besides just giving some brief overviews about PNES in a very user-friendly, general, easy to understand way, she offers some self-help treatment suggestions for things you could do to help reduce your episodes. So what I was surprised, because as a psychologist, I thought I was going to learn something really different and special here, but it actually was just very basic information about how to cope with anxiety and depression and anger and things like that. Just some basic CBT type skills. So if you're a professional and you already know how to work with people on those issues, that's basically what it says in the book. So if you're someone and that's what's driving your PNES and you want to learn more about how to do that on your own, you could just check out that book, and it's phrased in a very easy to understand way. And also, if you want to understand people's firsthand accounts of seizures, there's a nice collection of people describing their personal experiences with PNES in the book in our own words by Mary Martrios and Lorna Myers. There's other similar books out there as well that have personal stories that are put together in a book form. So you could check all those out on Amazon. So learning more about this could really be a source of comfort and reduce your stress level if you're the one suffering from it, make you feel like I'm not going crazy, this is a real thing. All right, so this is the more psychological part of the presentation today. So I think one of the things that could help is to understand why am I getting these episodes? Like, what is this PNES all about? What purpose does it serve? So here are some ways of conceptualizing PNES based on people's experiences and what professionals are saying. So on the one hand, the main thing is that it serves in some way as a coping mechanism. And it's not done deliberately. It's paroxysmal. It comes out of the blue. It's a reflex-like strategy that could actually help you cope with some overwhelming emotions or stress or trauma that it's hard to face consciously and directly. And after the PNES episode, as I mentioned in my first video, I believe it was the first video, that your arousal level actually goes down a little bit. So it serves to reduce some of the stress levels that you have and make you feel a little calmer. So you may not realize that consciously, but it actually helps to help you manage certain things. And if it's hard to face them, it kind of gives you a distraction and something else to happen. So it seems like a little like, why would I choose this? Well, you're not choosing it, but your body figured out how to do this as an attempt to try to regulate you, as an attempt to try to cope with certain things. Of course, there's other ways you can learn that maybe be preferable to that, but somehow, and we'll talk about more about why this could occur, your body figured out that in some ways this could help you deal with overwhelming things. It could serve as, secondly, a form of dissociation and avoidance. So if it's hard to cope with something and face it, or you're afraid of feeling overwhelmed on some level, it's kind of encapsulating the stress and putting it somewhere else so that you don't have to consciously deal with it. So it's almost like a part. So like when they talk about, we have different parts of ourselves, that I have maybe an angry part of myself, and I have a part of myself that sometimes acts like a bratty child, and I have another part that acts like an adult and functions at work, and I have another part maybe that is the seizure part that takes care of certain things that I haven't been able to fully cope with and integrate into my life. So it's kind of a separate part that's holding something for me. So in some way, it's a way to help me avoid and deal with things. It's also considered a communication disorder. So if it's hard for me to say things directly to people, maybe because I don't have the words, or I'm not really listened to, or people are kind of invalidating to me, it serves as a sort of a abstract form of communicating something. And so I might communicate somatically through my body, through my seizures, something that's emotionally on my mind. So if I learn eventually other ways to communicate, it might kind of help the seizures to subside. There's also a common pattern that they see in people with PNES, and I don't know if you could relate to that if you're somebody who does suffer from PNES. So there's kind of a bouncing back and forth between emotional underregulation and emotional overregulation. So when you're underregulated, you're not regulating your emotions, they might get more intense, more extreme. There might be more hyperarousal, so high energy, anxious, anxiety, anger, intensity. Emotional dysregulation is the term you would use in DBT. You might be more impulsive at times, hypervigilant, kind of like looking out for threat, either inside or outside yourself, and somatically preoccupied, kind of like scanning your body for anything that could feel wrong or feel like a seizure is coming on. And that could be part of this dysregulation, this emotional underregulation. On the flip side, you might flip to, okay, now I'm underregulated, now I'm going to be overregulated. So it could go to hypoarousal, so really low arousal, really low energy, kind of depressed, sluggish, sleeping. I might avoid things a lot, even outside of using the seizures as avoidance. I could avoid in other ways because that might be my style of trying to cope with difficult things. I might just try to not deal with them. I might dissociate in other ways, even other than the seizures. I might kind of zone out at times or lose time, or not fully feel like I'm there and present. And that's my way to deal with something overwhelming. They say it's pretty common for people to have what they say is alexithymia, which means I might have a hard time having words to describe my feelings, or being able to label my feelings or recognize my feelings. So instead of being able to put words to it, it comes out in a different way, perhaps as a seizure at times. Might have a sense of over control, trying to over control my emotions, my world, my relationships, my thoughts, my behaviors. And that's another attempt to deal with the underregulation. So it's extreme again. Repressing and suppressing, distancing and disconnecting from myself and from others, and internalizing, like taking things inside but not saying anything about it and just pushing it down. So I don't know if any of this sounds familiar, but it could kind of be a little bit of both, a back and forth, and one's compensating for the other. Because after a while, like if I'm over-regulating so much, eventually it may not work and I might explode back and be under-regulated and dysregulated and very emotional. So it could be a back and forth. Okay, so here's an interesting concept that's part of the conceptualization specifically of PNES that's developed by two men named Ruber and Brown. And there's an article about this that you could look up on the internet for free. So they call it a seizure scaffold. So a scaffold, if you think about it, there's a scaffold on a building. It's like it's kind of like a mesh structure that the workers could climb up on to kind of keep the building a certain way while they're working on the bricks and they're working on the building. So what keeps the seizure in place? How is it scaffolded in my brain and in my physiology and my psychology? So they say that it's almost like this conceptualization, this ball of perceptions and motor activities that's sort of stored in my brain in a certain kind of a way. And it was stored there because of various experiences I might have had over my life that kind of just formed this idea of a seizure that's kind of in my brain. So I might have had, let's say, seizure models that I've seen from others. So they say, actually, interestingly, that people with PNES are much more likely to have witnessed somebody having a seizure before their PNES developed, as compared to people with epilepsy. So 66% of people with PNES have witnessed someone having a seizure versus only 11% of people with epilepsy. So there's some idea just from witnessing someone having a seizure of what that looks like and what that whole process is. So that gets stored in my brain. I might have had my own experiences. Sorry, I hope you don't hear that siren, but there's something going on outside. Anyway, I might have had my own experiences that were sort of having some features that sort of were similar to epilepsy, or seizures that are stored in my brain as well. There might be certain reflexes that kind of mimic seizures, such as a freeze or a startle reflex that kind of have elements of it. Maybe certain things from prior illness or injury, or other physical symptoms I might have had that mimicked certain aspects of it. So it all gets kind of put together, cobbled together into this idea of a seizure. I might have had experiences even with loss of consciousness, or even the trauma I might have had certain elements of it, hardwired behavior tendencies. So all these things together, or some mix of them, or some parts of them, kind of came together, and for me became the seizure scaffold. So then they have this diagram here. And flowcharts, for me, like kind of scramble my mind a little bit, but I'll do my best to explain it to you. So if we look on the bottom, this is the seizure scaffold. So this is the seizure idea that's kind of stored in my brain. So that's kind of at the ready, waiting for me to go through something and to activate. So it's not activated all the time, but it's back there. So let's say on the left here, I'm sensing some internal or external cues that make me feel a sense of threat and increase my arousal. So make me feel a little bit more anxious, a little bit more angry, irritable. So maybe I feel rejected by somebody, or I feel like someone was a little bit rude to me, or I lost my job, or maybe I'm feeling some kind of physical sensation that's making me concerned. So that could be a sense of threat that I'm experiencing as a result of those perceptions I'm having. At the same time, I also might have a certain level of chronic stress. So maybe I have some family issues or some work issues or socioeconomic issues that are kind of like creating this overarching level of stress that is kind of hanging out in the background of my life. And I'm trying to inhibit it. I'm trying to stuff it down, but it doesn't always work. So my inhibitory processing is not fully working. I'm trying to deal with it by not fully letting it in, but it's not like an effective method all the time. So when these things are operating, these three things, sometimes it might activate that seizure scaffold and create like the PNES seizure-like event. And if this happens repeatedly, it becomes PNES sort of like a disorder. So it becomes like a pattern in my life. It's become something I'm dealing with over time. Okay. So in a linear way, because I think a little bit more linearly than in this form, it's sort of like you have the baseline of chronic stresses and emotions, internal or external. There's certain kind of triggers that further increase your arousal or your stress level. So it's not just the basic stuff that you're dealing with every day. Now it's something in addition to that that's creating a sort of spike in your day. And I'm trying to cope with it with my over control and suppression strategies, but the stress is building to the point where it's not fully working. And then the seizure scaffold gets activated and the seizure occurs. So it's almost like shaking up a bottle of soda. So the suppression strategy is like tightening the cap, but eventually you might shake it so much that the cap can't stay on anymore. And that's sort of when the seizure might break through. So that happens, and then you emerge from the seizure with reduced arousal. So your brain registers this as like, this is something that might help me feel a little bit better. So your brain learns to keep doing this, and it could become a pattern. And so if you haven't been diagnosed properly or treated properly, this could go on for several years. And I think they said, I could be wrong with the number, but the average person might take them 7 years to get the correct diagnosis, which is really sad. And it might be a reflection of the professionals not being able to use the right techniques and methods to really work with this. But the sooner you get the diagnosis, the sooner you work with it, the better off you'll be. Okay, so treatment strategies. So in looking at some of the main ones that they were talking about as more common PNES specific treatments, they all talk about the importance of keeping a seizure diary or a log. And I could definitely see this as important because there's many different factors that can lead to the seizure, different kinds of emotions and trauma and stressors and things like that. But you have to figure out what is it for you, not just as people in general. So you have to figure out, okay, when I had this seizure today, when did it happen? What time did it happen? How long did it last? Where was I? What did it look like if I happen to know or someone witnessed it? What was I doing at the time? And chances are it may not have been anything stressful, because they say that unlike a panic attack, where it's very clear that there's an immediate stressor right before the panic attack, that sometimes there's a period of calm and you might just be sitting there watching TV and not doing very much at all. And then the seizure comes out. But it was something maybe a day ago that was stressful that was really the trigger. So you have to look back and think, well, maybe it wasn't something immediate, but it's been something kind of going on recently. And maybe that was part of the stress and part of the reason why the seizure happened today. So you got to keep your mind open and look carefully, be a detective. So again, what happened earlier in the day or week? So look for triggers that might have contributed. So if you keep a seizure diary or log and you look at all the different episodes, you might start to see a pattern. So maybe it's certain common things or common times of the day or common locations or common stressors that are leading to this. And that's going to be the key to your treatment. So you got to look at what are the contributing factors and then start to work with those. And as a DBT person, I would say it's the same kind of thing as doing a behavior chain analysis on an episode of self-injury. So you would look at what are all the contributing factors, what happened next, what were the emotions, what were the thinking, what were all the things that led up to it. And then you work with those specific things as you try to reduce the self-injurious behavior. So similar idea, but you're working with something that comes on involuntarily, but you still can have power over the causative factors and create a better outcome. So you could do a seizure diary or log however you want. You could do it a paper and pencil in a journal or a black and white notebook. You could do it on your computer, just open a Word file and do it there. And they even have some apps that you could use There's apps, one's called Epsi, Seizure Log for Epilepsy. Another one I saw was called Epilepsy Journal. And you could record your stuff on there. And there's even ways to like share that information with your treatment provider if they're also on it. So that could be really helpful as well, because then they're in a loop of what's going on with you and can help you with it. Okay, so here's some core main categories of psychological treatment strategies that were offered. Now, again, it's important to tailor it to your specific situation, but these are some general ones that they talk about. So number one is mindfulness. So instead of having dissociation, which is part of a PNES experience for a lot of people, and also one of the co-occurring conditions, mindfulness brings you back into the moment. It helps you stay present and tune into your physiological, emotional experiences without judgment, without trying to force them to go away, without amplifying them, just letting them flow in and out, without overreacting to them and revving yourself up and making it worse. It's just kind of that practice of observing them in a non-judgmental, calm way. And they also talk about being mindful. Gaston Basslet, who was one of the people I mentioned before, speaks about being mindful of your values. So bringing back to mind, like, what do I really want in my life? What's important to me? How do I want my life to go? And how can I make choices in those directions instead of letting seizures run my life? So all those things can be an important practice. And you could, if you're interested, you can learn more about mindfulness in a million places, because there's a million books on mindfulness now. There's all kinds of stuff on the internet. I also have DBT mindfulness skills on my YouTube channel. There's a playlist called DBT mindfulness skills with several videos outlining that. I would also definitely recommend getting an app for free. You could get apps such as Insight Timer, which I think is excellent, has thousands of free meditations. Calm, Headspace, I think, is another one. There's all kinds of stuff out there to help you practice mindfulness. So you just have to commit yourself to doing it. That's the hard part. Okay, so next, they talk about emotion regulation and distress tolerance. Now, these are DBT words for this, but that's basically what they're talking about. People say in the book where they talk about people's, in our own words, people's experiences with PNES, one of the things that several of them described as being helpful was reducing my stress level. So learning to cope with stress better, learning to experience your emotions, put words to your emotions, and learn how to regulate them. Let some of them in, but not be overwhelmed by them, and feel them rather than just suppress them, and find other coping strategies to have that fuller experience of emotions and experiencing some stress, but regulating it, making certain informed choices in your life to help you say no to things so you don't take on too much and get too stressed. So all those kinds of things are helpful, especially since, stress and emotion dysregulation or overregulation contributes to PNES episodes. So one of the things you could do with that is reduce the vulnerability toward having an episode in the first place. So if you're coping in your everyday life better, it reduces the likelihood that a PNES event will happen. And a lot of times people have early warning signs or aura-like things before it becomes a full PNES episode. And it's possible to notice that and be with that and cope with it in a way so that it goes back down and doesn't become a full-blown episode. So there's ways you could practice to stop it early before it gets out of hand. And that could be something that you could add to your repertoire. So if you want some key skills on this, and again, when I looked in Lorna Meyer's book, it was just basic stuff about anxiety, depression, and anger. You could look, if you want, at any kind of resource that helps with that. You could look at my YouTube channel for the DBT emotion regulation skills. I have all the skills in the module, DBT distress tolerance skills, all for free. If you're more on the over control side, like you tend to suppress things and hold things back and not feel things, I would look at the radically open DBT skill set, because that's more for an over controlled coping style rather than an under controlled coping style. All right, so because we describe this as a communication disorder, it's important to learn better communication strategies. So learning how to be more assertive and identify your needs, learn how to express your needs and preferences, to set limits and boundaries with people, to share what's going on rather than just keep it to yourself. All that kind of stuff to replace the need for the seizure to communicate. You also might want to practice developing scripts for explaining PNES to other people so that you don't have to feel like I have to hide out from everybody. So if you explain your PNES and what it is to a friend and what they could do to help you if that happens, you might feel less inhibited in terms of going out with that friend. Now they understand, they're on board with everything, they understand what's going on, and now, you could widen your world a little bit. So some interpersonal effectiveness skills on my channel, if you want to check it out, is the DBT Interpersonal Effectiveness Skills playlist, Interpersonal Effectiveness Extras, which is some extra skills that are non-DBT related to interpersonal skills, and also the Radically Open DBT stuff, which has a lot of things about communicating and being authentic and saying what you mean, and figuring out a way to say what's on the inside and put it on the outside, and working with your valued goals and relationships and all that kind of stuff. A lot of good stuff. So next thing, improve daily functioning. And this would be something we'd recommend for almost any psychiatric problem, that despite the problem, I'm going to find a way to keep functioning the best I can at this moment. So instead of making my world smaller and smaller, I'm going to try to make it stepwise a little bit bigger again, a little bit bigger, venture out a little bit more, see if I could go back to school if I'm hiding out from school, or go back to work part-time, or go to the store again instead of just ordering things online. Go out with a friend who understands my PNES instead of not going out at all. So try to make your life, if you get a life a little bit more, you'll feel better about yourself. You'll feel better about what's going on in your life. And that in itself might start to help with the PNES episodes. And finally, I think it's it's important to work with any resistance you have about changing. So there's part of you that probably really wants to get rid of these episodes and be done with it and feel better and be a normal person, but they have been serving a purpose for you. Again, so they've been helping you cope in some way, maybe avoid things, communicate. And so because they served an important purpose, it's hard to give them up, even though they've been creating problems. So you have to understand within yourself, what's my ambivalence all about? Which part of me wants to get better and why? And which part of me is afraid to get better and why? And to make that conscious and be aware of all that and work with that. So you could use dialectical strategies, pros and cons, internal family systems part work, because it's part of yourself wanting different things. Motivational interviewing might help in that way because it's keeping you focused on your reason for getting better and helping you move in that direction. But it's really important to deal with this and not just assume that 100% of you is going to want to get better. It's normal for part of you not to want to get better, but you still have to look at that. So on my channel, I would say the DBT middle path skills are very important, because the middle path is kind of like working with the dialectics and the different parts of you, and pros and cons from the stress tolerance module. Okay, so here are some key books I would recommend if you want to learn more about the psychological treatment of PNES. So the first one I referenced earlier by Lorna Myers has some very basic information that you could use even if you're working with this on your own. Again, for professionals, you probably know a lot of these kinds of treatment strategies already, because they're just very basic things for anxiety, anger, depression. The next two are the 15-week cognitive behavior therapy informed psychotherapy, which is like the one that they developed for PNES specifically. It's like a structured program, a manualized program, and each week you cover some different things that might tackle common issues that are driving the PNES. And some research has been done on those, and they've shown to have some effectiveness. So you might want to check it out yourself if you're the person with PNES. If you're the professional, you could look in there for some ideas and incorporate it into your treatment with the person you're working with. Okay, so there's a therapist guide and there's also a workbook. So the workbook is for the person with the PNES and the therapist guide is for the therapist. But, if you're a patient, you could read it too. I mean, it's not going to hurt. And finally, the last book, Psychogenic Non-Epileptic Seizures Toward the Integration of Care. That's the one that Gaston Basslet co-authored. And he's the one I spoke about before, who talked about using mindfulness with PNES. So I haven't read that book, but I'm guessing that it incorporates mindfulness and some other related strategies in helping. Okay, so here in a more practical note, to help you feel more motivated to expand your world, it's important to develop a PNES response plan and to share it with the people that are in your life that are more likely to be there. So think about what your preferences are for what should happen if you have an episode. And make sure people know about it. So this is part of the communication that you could practice as well if you're doing your interpersonal effectiveness skills. So on your plan, you could specify what's a quiet place you can go if you feel a seizure coming on. And you should specify this in different locations. So where can I go when I'm at home? Where can I go if I'm at work, if I'm at school, if I'm at a store, if I'm at a friend's house? Like maybe there's different places you commonly go, and you could picture in advance, where could I go in that location if I feel a seizure coming on, so I could have it safely and not get hurt. Maybe part of the plan is a way to decrease external stimuli so that it's quiet and you feel more comfortable and safe. Some people might even carry around a small pillow, or maybe the person with you could help remove any unsafe objects in the area so that if there's movement within your seizure, you're not going to hurt yourself. You might specify too if you want somebody present or if you'd rather be alone. So once you're safe, you might prefer just to go through it by yourself and then have someone find you when you're finished. Other people are scared to be alone and would feel abandoned, would prefer somebody to be there. So it's important to let people know what you'd prefer to happen. You could put this down on a laminated card if you want and keep it on you, or give it some printed out copies to people so that they're aware. But if you think you're going to be in a place where someone might not know you, it could be helpful to have that kind of a laminated card with your preferences on there. Okay, so tips for people who are witnessing an episode, just so that you could help it go more smoothly. So this could be family or friends of people. It could be professionals that are in the area. The main thing is, don't take the person to the ER if you know for sure it's PNES, unless they get physically injured during the episode, because it's more likely that in the ER, they're going to give unnecessary treatments because the doctors may not know much about PNES. It might be medications. It might place the person at greater risk if they go there. So they say, unless your episode really looks different than usual, or it's very, very long, and that's not something that normally happens for you. Obviously, if it occurs underwater, that would be really scary and dangerous. If you're pregnant or if you have uncontrolled diabetes, those might be some more extenuating circumstances that may prompt someone to go to an ER, and that would be the safer thing to do. But normally speaking, they say it's better not to go to the ER, and you should let people know that. If you're a witness, don't hold the person down or restrict their movement, because that could lead to greater injury. Don't try to pull them out of the seizure, especially by noxious or painful stimuli. Just let it pass normally. If you try to, do a sternal rub or, pinch their body or poke them in some way or shake them, it's just going to create more stress and might actually prolong the seizure. And in the long run, it's not really helping the person learn how to come out of the seizure or learn how to avoid seizures. That would be done more with some of the psychological methods I discussed before. So learn how to, deal with your stress better and learn coping skills. And those are the things that are going to help the seizures stop in a longer term way. Trying to pull someone out of a seizure right now isn't really going to do much. So you should just let it happen. You shouldn't put anything in the person's mouth, including medication, because that can be dangerous. It could be a choke risk. And important to remember that the person could be conscious. So you shouldn't say invalidating or judgmental things, because the person might hear you and it might be very stressful for them. Some people have reported that they've heard people say, "Come on, get up, get up, get up," or, "You're faking it. See, look, she's just faking it." And it could be very stressful and hurtful to the person. So please always remember, that someone could be listening and that you should be kind and compassionate. And if anything, just be quiet or give them space. All right, so here's some of the treatment outcomes they found through some research. So they say, interestingly, about a third of people get better after they're given a PNES diagnosis. So let's say you had seizures for a while and you're really confused as to what was going on, or you're convinced you had epilepsy and you're worried about what that means for you. And, the stress of just not even knowing what it is or thinking it's epilepsy could perpetuate the seizure activity, the PNES episodes itself. So sometimes just finding out, guess what? It's not truly epilepsy could be like a big weight off for some people. And having that weight lifted off your shoulders can reduce your stress level to the extent that the PNES episodes just stop. So that's really good news for some people. This is most likely to happen if you're a child or an adolescent, or if your PNES history is relatively brief, so it hasn't become an ingrained seizure scaffold kind of pattern. And if your underlying psychiatric condition is relatively mild. So those are some of the factors that contribute to this getting better spontaneously after your diagnosis. About another third get better after psychological treatment. So, following some of the things I was saying earlier, if you work with that, you could get better, and that's some good news. Some of the studies showed that if the person fully engages in treatment or does those 15-week, PNES related treatments, and they do their homework and they're invested, that after about 3 months, people could tend to get better. So that's also some good news. Unfortunately, about a third of people have treatment-resistant PNES. So it may not fully go into remission. Maybe you get a little bit better. Maybe it takes much longer. So it could be hard. I mean, you might be that third. And you're more likely to be this third if you have comorbid anxiety, depression, PTSD, intellectual disability, or personality disorders. So more severe or entrenched psychiatric issues can make it harder to treat, just like it would be harder to treat them even without PNES. Sometimes people come to therapy even without PNES and they say, well, I'm afraid of riding in elevators. And okay, so we do some exposure treatment and you work out your elevator fear, and in 10 weeks you're done and you're good. Other people, they come in with some phobia, but there's a million things behind it that's making it much more complicated, and it's a much longer and more complex treatment. So it's the same thing with PNES. If you have more complex underlying conditions, especially psychiatric, psychological type things, it is going to take longer and it's going to be harder. And so you have to be patient with yourself and keep working at it. So other things that could get in the way, problems with self-perception. So like maybe low self-esteem or attacking yourself or, hating yourself, problematic interaction with others, including family discord. All that can contribute as well. Could be an ongoing stressor that makes it hard to get through it. If you have a significant trauma history, that's hard to treat in general. And so it's also going to be hard to treat here. And if the trauma is prompting the PNES may not get fully better until the trauma gets better. Again, they're showing some hope with this prolonged exposure for PTSD and PNES, and that might be something you could try. Other times you might need some other kinds of trauma-related treatment. So if you have some of these underlying things and you want to learn more about them, I have some stuff in my channel as well. So I have videos on attachment styles, developmental trauma styles, and sensory motor psychotherapy. So some of those might explain some of the underlying things that are a struggle for you, and the sensory motor psychotherapy could offer some techniques you could use to work with them. But sometimes, even if your seizures don't fully remit, you could still find a way to function better and find some ways to have some full and meaningful lives and interactions. All right, so I know this was a bit long today, but I hope it was useful to you. So thank you for listening, and I'll see you the next time. All right, thanks everybody.